Hi, everyone. For those who don't know me, I joined as faculty on this ECHO when I was practicing as a psychotherapist and a clinical supervisor at Seaport, PCHC, which is in Belfast. And my background in working with moms who have opioid use disorder, pregnant women with opioid use disorder, is that I've been working in the field of substance use problems for the last 10 years or so. And pretty early in my career, I recognized how difficult it was for women to get adequate care because of the barriers associated with being a mom when they had addiction. And so at Seaport, we started Mother's Group, which was a psychotherapy group. We had a medication for opioid use disorder program, and it was a psychotherapy group for moms specifically, and they could bring their kids. And so we kind of over time learned how to specifically help that population. And I really enjoyed that work. And we also had a collaborative of providers from our area that got together to try to improve care. And I'm currently working in Portland as the director of mobile crisis here with the Opportunity Alliance. Okay, next slide. So the importance of talking about best practices for behavioral health for perinatal is that psychiatric and substance use disorders in pregnancy are correlated with negative outcomes for mom and baby. Women who have mental health disorders are less likely to receive prenatal care. They're more likely to use alcohol, tobacco, and other dangerous substances. Studies have pointed to low birth weight and growth restriction in babies that are born to mothers who have depression. Distress during pregnancy can lead to preterm labor. Anxiety and depression late in pregnancy are correlated with a number of negative health outcomes for mom and baby, including preeclampsia, operative delivery, infant admission to special care nursery for respiratory distress, hypoglycemia, and prematurity. Opioid use disorder during pregnancy is linked to maternal death and adverse health outcomes for the baby. And postpartum psychosis, untreated, is a medical emergency, and in severe cases, it can result in suicide or infanticide. Next slide. So pregnant women are actually less likely to have an active alcohol use disorder and have a lower risk of having a mood disorder than other women, but they're much more likely to have a major depressive disorder postpartum compared to people who have not been pregnant. Women who are pregnant are less likely to receive mental health care. Providers and patients who abruptly discontinue psychotropic medications after discovering a pregnancy, it's frequent that providers and patients discontinue psychotropic medications after discovering pregnancy. And when that happens, women who have major depressive disorder or bipolar disorder are more likely to have a relapse in their symptoms. Common mental health disorders experienced during pregnancy include mood disorders, anxiety, PTSD, and ADHD. All right, next slide. There's a real stigma around pregnancy, substance-affected pregnancy. Women know about this. They've often heard others speak harshly about substance-affected pregnancy, and they're fearful of judgment and rejection. It takes a lot of courage to engage in care. A lot of women who are going in for prenatal care who are dealing with an opioid use disorder are worried that DHS is going to take their child away. So it's important to speak about this as early as possible, openly and compassionately, and to speak transparently, not coercively, about what impacts the outcome of CPS assessments, so women know and can be informed early on. Next slide. So depression and anxiety during pregnancy are fairly common. 1 in 5 women develop postpartum depression, 1 in 10 develop postpartum anxiety. ACOG recommends that all OB providers screen for anxiety and depression during pregnancy and in the postpartum period. A biopsychosocial assessment when starting medication for opioid use disorder helps to identify depression and anxiety and other barriers to care. Coordinated psychotherapy and medication can be helpful treatments. And when those don't work, there are brain stimulation methods such as ECT and TMS. Next slide. So evidence-based psychotherapy interventions for postpartum depression and anxiety include CBT, which most of us are familiar with, but it involves various techniques aimed at highlighting the relationship between thoughts, feelings, and behaviors. Interpersonal therapy, which focuses on relationships and interpersonal problems. Non-directive psychotherapy, which is it's client-centered psychotherapy, and it's essentially directed by the client, and it's empathic and helps. It's aimed at helping the client to gain insight. There's some evidence for hormone therapy, and then other methods include omega-3 fatty acids, ECT, bright light therapy, acupuncture, massage, and exercise. Next slide. So most pregnant women who come into treatment with opioid use disorder have a positive screening for adverse childhood experiences. And childhood trauma exposure increases vulnerability of low birth weight delivery associated with prenatal mood disturbance. Trauma-related symptoms can be triggered by pregnancy or exacerbated by pregnancy. A lot of times women feel kind of out of control of their body and vulnerable. And if they have a history of sexual abuse, it can really be a potential barrier to adequate prenatal care. It's indicated to screen for trauma history in pregnant women. Next slide. So evidence-based psychotherapy interventions for PTSD include CBT, cognitive processing therapy, which is a type of CBT. It's like 12 sessions of more directive therapy that helps clients to challenge some of their unhelpful beliefs about their trauma and to explore alternatives. Prolonged exposure, which is a way of helping women increasingly talk about their trauma so that they have less of a physiological response to discussion about it or triggers. And so it causes less distress over time. Other conditionally recommended approaches are brief eclectic psychotherapy, EMDR, narrative exposure therapy, and medications. Next slide. So treating ADHD in pregnancy is tough. For ADHD, pharmacotherapy remains the first-line treatment for ADHD, usually with psychostimulants, and research is kind of conflicting about whether to continue doing that during pregnancy or not. Psychotherapy using psychoeducation can be helpful, but retention of patients with ADHD is tough in therapy. They can be less likely to continue if they're not treated with medication. And ability to manage medication as prescribed is a treatment consideration in patients with substance use disorder, especially at the beginning of recovery. All right, next slide. So SAMHSA recommends that a comprehensive assessment be done to assess for opioid use disorder in pregnant women, which includes a medical evaluation and a biopsychosocial evaluation. It's important to develop trust and rapport. Probably the most important way to assess is to be able to have that trust and have a direct, non-judgmental conversation with patients. The World Health Organization recommends evidence-based ways to evaluate for substance use problems. And some of the screenings that have been standardized for pregnant women include ASSIST, 4P plus, and SERP-P, which is SERP-P is substance use risk profile pregnancy, I think. Others include the NIDA quick screen, CRAFT, which is for adolescents, and WIDUS. As discussed in other presentations, toxicology testing can be helpful with saliva or urine or blood. Next slide. Some evidence-based methods for treating opioid use disorder. First and foremost, medication for opioid use disorder is effective at preventing overdose, increasing treatment retention, and preventing relapse to active opioid use disorder. And behavioral or psychological approaches can help with treatment, but they have limited efficacy on their own, according to the research we have now. And the helpful measures are contingency management, CBT, MI, and structured family therapy. Anecdotally, in my experience, group therapy is really supportive to people, especially women who don't have a lot of supports coming into recovery, but we don't have a ton of research to support that. I think it's still useful to do. Next slide. Choosing levels of care is important. This is the ASAM criteria here, and it's actually like proprietary guidelines. So you pay ASAM which is the American Society of Addiction Medicine, to train your staff and to get access to their rating scales and things. But it's a helpful way to conceptualize levels of care in substance use treatment when you're talking to a pregnant woman. Their dimensions are acute intoxication and or withdrawal potential, biomedical conditions and complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use or continued problem potential, and recovery living environment. And kind of the less stable people are on each of these dimensions, the higher the level of care is indicated, while also considering that the least restrictive care that will, help a person is what you want to aim for. So if somebody hasn't tried a lower level of care, you kind of can lean toward that in the beginning. And different levels of care include outpatient services, IOP, partial hospitalization, residential rehab, and then the more medically managed inpatient settings for detox. And of course, you need client buy-in for any of these. So having a discussion about what types of treatment are available and what kind of challenges the person is dealing with is helpful. Okay, next slide. So integrated care for co-occurring disorders. Up to 56% of people with serious mental illness also have a substance use disorder. People with co-occurring disorders are more likely to be violent, be hospitalized, incarcerated, homeless, infected with HIV, or infected with other diseases. Most people who receive any treatment at all for co-occurring disorders receive it separately in a fragmented fashion. And it is more effective when done concurrently in an integrated fashion. And it's more effective at helping to reduce all of those problems listed above, reduce hospitalization, increase housing stability, reduce transmission of infectious diseases, and just improve treatment outcomes. Next slide. It's helpful when you do need to refer outside of your organization. Seaport was really nice because it is an integrated care facility. It's the health home, so we had a lot of services under one roof. And this is what MaineMOM is aiming to do, is to have as much coordinated care as possible. But when you do need to make a referral outside of the office, it's helpful to do when women are actually in your office. Warm handoffs can really reduce anxiety for patients. If they hear a voice, see a face, know a name of somebody, it really reduces barriers and increases the chances that they're going to follow through with the referral. And so you can do that on the phone or virtually if you can't do it in person. Women might not be able to accept the referral the first time. Sometimes they need time to think about it and feel more comfortable with it. So gently keep trying, don't give up. It is useful to develop relationships with providers that you refer or accept referrals from regularly. Communication and feedback help to eliminate barriers to quality care. And sometimes it's just chatting on the phone and saying, hey, how's your program going? This is how mine's going. Call me if you have any problems. It doesn't take that long, but it helps to increase coordination. The most accepted method for retaining women in treatment and preventing relapse or overdose is medication for opioid use disorder using methadone or buprenorphine. And it's just helpful to remember that medication increases may be necessary during pregnancy and have not been shown to directly increase symptoms of neonatal opioid withdrawal syndrome. Next slide. So common barriers in this population to effective behavioral health interventions and things you want to consider are housing insecurity, legal challenges, infectious diseases such as hepatitis C, other co-occurring mental or physical health problems, financial insecurity, and problems with transportation. And so, when we got our collaborative together of providers in our area, we would all talk about these kind of things, these barriers, and try to bring people into the collaborative who could help, whether they were specialized case managers or people from the local transportation broker or whatever, just to try to eliminate barriers or smooth things out as much as we could. So there are things you can do to improve things in your area. Next slide. So no wrong door. It doesn't matter what healthcare program you have. It is helpful to identify substance use disorders in pregnancy and make appropriate referrals. We're dealing with a whole person, and so whatever door they walk into, it's good to capture them there and eliminate some of the cracks for them to fall through.